Great. So this is part one of chapter 38 on emergency cardiovascular life support. Um, in this chapter, we're going to be discussing kind of the causes of sudden cardiac death or cardiac arrest, how to identify it, or different airway emergencies, how to perform those basic life-saving skills that you learned in BLS. Um, And then also in part two, we're going to be talking about different drugs and monitoring that we do for patients in ACLS and post cardiac arrest care. So why all of this is important to you is because as a respiratory therapist, you're going to be a kind of a cornerstone member of that emergency care team. So medical responses happen in the hospital for a number of different reasons, and respiratory therapists are kind of that primary person who responds to those medical emergencies. So you'll go to probably the respiratory department probably attends more codes than any other department. So even, ER nurses and ICU nurses might respond to codes in their own departments or on their own floors, but respiratory therapists have to go everywhere for codes with the exception of OR. So we attend a lot of codes. We're right at the head of the bed for all the codes. So it's really important that you kind of understand the process, understand how to be a good team member, and then understand your role in managing the airway. So, your primary purpose there is to manage the airway and provide that ventilatory support to the patient without interfering with compressions and venous return and cardiovascular support. So, we're going to talk about some of the physiology of that and things to think about with the types of patients that you're coding that can kind of help facilitate maximizing that ventilation and perfusion when the patient's heart's not working. Again, we'll talk in the second part about some of the drugs we use in the electrical therapy and how that kind of helps aid patients in the resuscitation process. And then what types of things you should be looking at and monitoring when the patient's in the middle of this medical emergency, and then what you should be monitoring and looking for afterward. So, sudden cardiac arrest is the leading cause of death in many parts of the world. So it's a primary reason that patients over the age of 40 in the United States and in many other parts of the world die. So your book mentions that about 500,000 people a year experience sudden cardiac arrest and receive some form of attempted resuscitation. So obviously in the hospital, there's a lot of skilled providers on hand. So your likelihood of successful resuscitation goes up when you have skilled practitioners on hand, and then the equipment necessary for the resuscitation efforts. So about 23% of all those cardiac arrests are going to present with what we consider pulseless ventricular rhythms. So you've learned about those in CP Phys, and we will, discuss those more here and help how to identify individual rhythms. And really, it's important for you guys to understand that resuscitation efforts, for them to be successful, we need to be doing high quality compressions with effective ventilation and have the ability to deliver electrical shocks to the patient to kind of bring them out of those irregular disordered arrhythmias and back into a more organized rhythm and a functioning perfusing heart, right? Okay. So the goals of basic life support is to what we're talking about with basic life support is those initial response steps when we've identified cardiac arrest in a patient. So what do we do initially? In this section of emergency care, we're really focusing on just ventilation and circulation. So providing rescue breathing and high quality compressions to the victims to try to maintain ventilation and circulation until we get a more qualified team there to administer the medications and the electricity to the heart. So your book kind of goes through some steps for administering BLS. So the first thing we should always do when we suspect cardiac arrest or we come across a patient that we believe is unresponsive is to double check for movement or response, and look for breathing. So, you're going to approach the patient, kind of verbally try to stimulate them, physically stimulate them to try to elicit a response. If there's no response, you can check very quickly for breathing. If you don't identify breathing within 10 seconds, next step, which is very important, is activate the emergency response system. So if it's in the hospital, you're going to be pushing the code button and getting additional team members there to help with fill in the roles and make sure that there's enough people there to manage the situation. So next we're going to be looking at starting compressions. So if there's no AED right in the room, which, that's unlikely that the patient's going to code right in front of an AED machine. Even in the hospital, the code cart's not in every single patient room. So you're going to start off with chest compressions while you're waiting for the code cart to get there and the additional personnel to get there. So start off with chest compressions. You're looking to do 30 compressions and then pause compressions to provide 2 rescue ventilations. So if you're the only one in the room, you're going to be doing the compressions and the ventilations at the same time. As more people arrive, somebody can be doing ventilations while somebody compresses. The person that's in charge of ventilation is also in charge of airway patency. So they're going to be opening up the airway, checking for, and checking breathing. If the patient's not breathing, you're going to give 2 breaths. And what you're looking for while you're giving those 2 breaths is good, adequate chest rise. If the chest isn't rising with those 2 breaths, you want to reposition the patient's head and neck to try to open the airway better. You're going to recheck your seal with the mask. You can also look to see if the patient needs suctioning. After the 2 breaths, you're going to then immediately resume chest compressions. With the compressions, again, they want to be high quality chest compressions. So we want to make sure we're pushing hard enough or deep enough so that the sternum is compressing the heart against the spinal column. So we want at least 2 inches on an adult, and you want a minimum rate of 100 to 120. Okay, compressions. So you don't want to go over 120 because you're worried about when you go too fast, you're not giving that time for that heart to refill and venous return to happen. So your blood pressure is going to be low. Your cardiac output would be low. So your blood pressure would be low, and perfusion to your important tissues and organs would be low and reduced. So you don't want to go over 120, but you want to at least be doing 100 beats per minute. Okay. Once the AED arrives with the response team, it's important to make sure that we're putting that AED on, putting that pads on, pausing compressions to assess the underlying rhythm, delivering a shock if a shock is advised, and then going immediately back to CPR. Okay. So with that determining responsiveness, again, BLS begins with that recognition and that activation of the emergency team. This is a very quick step. You should not be spending a lot of time to triple check that the patient's not responsive. If you don't get a response from the patient right away, and if you don't see, adequate ventilation, you need to get that call for help and get that rest of that team there. So in kind of in the community outside the hospital, it's just important to know that when we teach like first responder CPR, we're telling telling members of the community that if they don't see any breathing or gasping from the patient, they can just assume that there's not a pulse. And that's really true because you guys all know from doing your assessments with patients, sometimes it can be very difficult to identify a pulse. You know, we don't want people out in the community to be, you know, vacillating back and forth of, did I feel a pulse? Did I not feel a pulse? It's just, let's just assume the patient doesn't have a pulse and start doing CPR, because if you don't, you're greatly reducing the patient's chance of survival. Um, in the hospital, we're checking for that pulse for 10 seconds, no more than that. Typically, we are palpating for a pulse in over a major artery. So a carotid artery in the neck, or the femoral artery is usually what we're looking for in adults and children over a year old. And babies, we're looking for like the brachial artery is usually what's assessed. So if the patient does have a pulse but is not breathing, that's when you want to just start rescue breathing. So you're going to start with manual ventilation. And you're going to, this is, I think your book has it incorrect here, where they say down in the actual paragraphs or the wording on like page 790, they talk about giving a rate of 8 to 10 breaths per minute or every 6 to 8 seconds. But in the chart, they say give one breath every 5 to 6 seconds at 10 to 12 breaths per minute. That is the current AHA recommendation. So there's a discrepancy there that I just wanted to point out. Trust the chart, not the wording in the paragraph below it. So if no pulse is palpable, that's when you begin compression. So if there is a pulse, if you're a hospital worker, which you all will be, you're checking for a pulse. If there is a pulse, you're just going to do rescue breathing, one every 5 to 6 seconds. If there's no pulse, you're going to start with chest compressions, 30 compressions to every 2 ventilations until an advanced airway is placed. Once an advanced airway like an ET tube is placed, that's when we can start doing asynchronous ventilation and compressions, where we're just doing continuous compressions and we're ventilating every 5 to 6 seconds again. So again, providing those chest compressions, you want to compress on the lower half of the sternum for an adult patient. Typically, most injuries that happen during CPR are going to occur because of poor hand placement during chest compressions. But I do not want you to be so concerned with hand placement or chest compressions that prevents you from actually doing compressions. We don't care that the patient might have a broken rib at the end of all of this, because if you're doing nothing or you're not doing it hard and deep enough, the patient won't survive this situation anyway. So you're going to compress on the lower half of the sternum for adult patients, and the rate should be a minimum of 100. So it is just as important to allow for good chest recoil as to have that good downward push. Okay. So what that means is that sometimes, and as we practice this in the lab, you might notice that people kind of rest on the chest during that release phase of the compression. So I'm actively pushing down, but then when I release, I'm still resting on the chest, which is still putting pressure on the chest, which is still can be causing a slight compression of the heart, which doesn't allow for good venous return to the heart, which then makes it so that the heart can't fill back up. So the next time I push on it to compress it, go lay down. Sorry, I just yelled at my dog. The next time I push down on it to compress it, it is going to not be full, and then it is not going to generate as much blood pressure and much cardiac output. Good compressions can produce a good, if you're doing quality compressions, you can get a good cardiac output, and, a reasonable blood pressure for the patient during those compressions. Okay. So some things that can help with that is you want to make sure the patient's on their back in the supine position and on a firm surface. So if you're in the hospital, a lot of times you need to put like a backboard underneath the patient during CPR to provide that firm surface to compress against. Or sometimes some of the newer, fancier beds have like a CPR mode that like will automatically create a firm surface and deflate the mattress for the patient. Um, so again, as we're practicing this in the lab, this makes more sense, but you want to make sure you're positioning yourself close enough to the patient so that you can use the weight of your upper body to, make a deep compression. um you know you guys we're all smaller individuals. None of us are 6'5", 300-pound muscle men. So you are going to really want to use your upper body weight over top of your hands to help aid that compression. So you're going to need to get as close to the patient as possible. This is why we have CPR stools in a lot of the rooms to try to get people over top the patient, higher enough so that they're kind of hovering over top the patient. Or, we need to put the bed down so that you're able to be more over the patient's sternum. So you want to identify the correct positioning of your hands by finding the lower part of the victim's or the patient's sternum. You want to find the center of the chest. So kind of looking at the nipple line, that's kind of the center of the chest. Place the heel of your hand on the sternum, and then you're going to put the other hand on top and lock your elbows so that you're doing this straight armed. So again, we're looking to perform those compressions with the weight of our body exerting the force. Okay. CPR, if you do this for 2 minutes and you have to keep cycling in for your 2 minutes of CPR, you are going to get tired. Your back is going to kill you the next day after doing a couple rounds of CPR. So it is physically taxing on the person that's doing the compressions. You want to compress the sternum 2 inches at a minimum. At that rate of 100 to 120. And then we want to minimize interruptions. So when you take ACLS, we talk about chest compression fraction, and that means 80% of the time during the code, you should be doing compressions, actively compressing the chest, and only 20% of the full time of the code should you be off the chest for things like rhythm checks, pulse checks, things like that. So we want to make sure that we're not interrupting CPR, or there are interruptions in CPR as minimal as possible. Okay. And anytime we interrupt CPR, it should be for no more than 10 seconds.
Our heart is an amazing organ. It works hard for us every second of every day, delivering blood and oxygen to every cell in our body. But when sudden cardiac arrest strikes, our heart suddenly and unexpectedly stops beating effectively and blood flow stops. Without any intervention, the brain, vital organs, and our heart will begin to die. Beginning CPR is the person's only chance of survival. Brain damage will start to set in within 4 minutes, and after 10 minutes, brain damage becomes irreversible. The power to save a life is truly in your hands. Performing CPR accomplishes 2 critical things. 1, compressions move oxygenated blood to the brain to keep the brain alive. And 2, compressions keep blood and oxygen moving to the heart muscle itself, so that it has the best chance of resuming a normal electrical rhythm after a shock is delivered. As you begin compressions, you are creating an artificial pump and doing the work of the heart manually. With each good, effective compression, you are building up pressure in the system, which will move blood around the heart and up to the brain. It does take time to get the blood moving with CPR, so it is very important to push hard and push fast to build the pressure up, which keeps blood going to the brain. Pushing down at least 2 inches allows for the heart to be squeezed and blood to move out. Pushing at a rate of 100 to 120 compressions per minute is necessary to keep blood pumping. Let's see what happens when we take our hands off the chest. Blood stops moving to the brain. It is for this reason that if you are taking your hands off the chest to deliver breaths or switching roles, it is critical to minimize time off the chest. Watch what happens when we don't push deep enough. Blood does not reach the brain. The same is true if we do not push fast enough. Watch what happens when we push too fast. The heart does not have time to refill with blood, therefore not enough blood gets pumped out. Watch what happens when we don't allow the body to decompress and allow the chest to fully recoil. The heart does not have a chance to refill with blood, therefore no blood gets pumped out. So remember, the key purpose of delivering compressions is to keep oxygenated blood moving within the heart and up to the brain to keep the brain alive. We need to push hard and push fast in the center of the chest. If ribs break, that's okay. What's not okay is allowing the brain to die from a lack of oxygen. So remember, you are their only hope. Do the best you can, and don't give up until medical help arrives or an AED is present. You can do it.
So slightly corny a little bit there at the end with the "you can do it," but I thought that was a good 3D animation of just so that you could see how your compressions affect that venous return, and then kind of a good discussion about the fact that it takes a while with those compressions for that pressure to build back up, and that perfusion to happen every single time you stop. And that's another so important reason why we shouldn't be doing a lot of stops in CPR. Okay, so just some slight variations when you're talking about chest compressions in children. With children, you want to make sure, again, supine, so on their back on a firm surface. You want to identify the lower half of the sternum again. With children, your compression rate should be at least 100 beats per minute, and you want to push hard enough so that you see about 1/3 of that anterior posterior diameter. So you want to compress like 1/3 of the chest in. So that's usually about an inch and a half in infants and kids. Okay. Or infants, and about at least 2 inches in children. With infants, so less than a year old, you want to imagine that line that's connecting the chest between the two nipples, so the nipple line. You typically, we are gonna put our both hands around the baby's chest, so our thumbs kind of overlap in the middle over the sternum, and then you are going to kind of compress the chest that way. So that's one way of doing it. The other way is putting your index and middle finger, or your middle and ring finger, on that sternum right below the nipple line, and performing the compressions that way. So really kind of depending on how small the infant is, doing the two-hand method surrounding the chest is easier on smaller babies, and probably the preferred method on smaller babies. But bigger babies, you might need to use the two-finger method on the sternum. And again, we'll practice each of these types of compressions in the lab. Okay, so because babies are so small, usually you're just using one hand for the compressions, and then the other hand is used to kind of stabilize the baby's head and keep their airway positioned while you're doing the compressions. So compression rate depth should be about 1.5 centimeters, and again, at least 100 compressions per minute. So in neonates, this is babies less than 30 days old. They have special considerations for chest compressions. So even if they have a pulse, but their heart pulse is really slow, chest compressions are indicated. Okay, so if you are responding to a medical emergency for a baby that's a newborn, even if you feel pulse, but the pulse is 60 beats or less, you're going to want to do chest compressions because that's not fast enough for the baby to have a good perfusing heart rate. So you're going to want to start chest compressions. But before you start chest compressions, you want to make sure that the patient's adequately ventilating. In adults, cardiac arrest is the main cause. So the heart stopping is the main cause of these medical emergencies. So we focus a lot more on, the heart and circulation in adults, but especially with babies and a lot of times even with peds, typically the cardiac arrest happened because first they went into respiratory arrest. So the first problem was that they went into respiratory arrest and their breathing wasn't adequate. And so I need to fix the breathing in order to fix the heart with babies and young children, typically. So for compressions, we're going to compress the lower third of the sternum, 1/3 of that anterior posterior diameter. So typically you're going to do a 3-to-1 ratio. So 1, 2, 3 with the compressions, 1 breath, 90 compressions, 30 breaths to achieve about 120 events per minute. So I'm going to do 30 compressions, or 90 compressions and 30 breaths all within 1 minute of CPR with babies. So thinking about some special situations that could occur that you want to consider with CPR. Near drowning victims, again, in near drowning victims, you are going to assume that it's probably the loss of airway and breathing that has caught, and then the resulting hypoxemia or low oxygen that is causing the arrest. So you still are going to operate kind of the same way but make sure you're moving the patient out of the water and onto a firm surface so that you can provide good compressions. A lot of times with drowning victims, it might have happened because of a cervical spine injury. I mean, there's always the signs posted everywhere, don't dive into unknown depth water, but people still get drunk and do stupid things, or just do stupid things without alcohol being the kind of catalyst of it. So you might want to assume, especially if it's unwitnessed, that maybe there was a cervical spine injury as well. So you, would want to stabilize the cervical spine in those types of situations. But if there's no sign of trauma or anything like that, then you can just perform the regular head tilt chin lift to open up the airway. Another very common occurrence, unfortunately, is opioid related medical emergencies. So opioid addiction has, just skyrocketed in the United States and over the last 20 years. So this is why Narcan is so readily available in the communities, because a lot of times you'll come across patients who've gone into arrest due to overdosing on, heroin, fentanyl, other types of opioids, analgesics. So you want to provide that basic BLS care, but in addition to that, you're going to want to administer intramuscular, so giving an IM injection of naloxone, which is the fancy name for Narcan, or intranasally, so you can kind of shoot a dose up their nose. So Narcan, again, is only going to be the reversal agent if they overdosed on opioids. There's a lot of patients that overdose on other things like benzodiazepines or other types of medications or substances. It is safe to assume it's an opioid and just give the Narcan anyway. It's not going to hurt anything. So you should still give it even if you're not sure what they've taken. Or even if you just are questioning it, you should just give it. It's not going to hurt anything. So Narcan, the mechanism of action is this medication attaches to those opioid receptors in the brain. So it's taking up those like parking spots in the brain on the cells so that it kind of blocks those opioid effects in your body. It's very effective. It works very quickly if it's going to work. So typically, once it's administered, normal breathing is going to be restored within 2 to 3 minutes. You can give multiple doses, and sometimes that's indicated if they're using stronger opioids. Fentanyl's a big one. Like, fentanyl's really tragic that's out on the streets and in the market for people to be able to abuse, because it's a very strong opioid. So sometimes giving one or more doses is necessary of the Narcan to get it to reverse. And it, like I said, again, Narcan's not going to hurt anybody. So even if you suspect they OD'd on something else, you can give the Narcan. Okay. Restoring your airway. So after calling for help, you need to, position the patient so that you can do either the head tilt chin lift method or the jaw thrust method if you suspect an injury. Okay, so we've gone over these methods in previous videos, but there's nice pictures on page 793 of your textbook that kind of shows you how to open these airways using both of these methods. Again, head tilt chin lift is the method that's recommended in most cases to best open up the airway. But if you suspect a spinal cord injury, you can do the modified jaw thrust. If their jaw is broken, you can't do the modified jaw thrust. So if you cannot maintain an airway with the jaw thrust method, you need to, regardless of your concerns for the B-spine, you can gently do a head tilt chin lift with that modified jaw thrust to try to get air into the patient's lungs, because again, if they're not ventilating, the likelihood of you getting them out of arrest is slim to none. So, you kind of have to kind of pick your battles here and try to do the best you can for your patient. So we consider breathlessness, we're checking for breathlessness by looking for chest movement. Usually they always used to say, look, listen, and feel. So you're kind of going to put your head down by the patient's mouth and nose, listen for their breaths, maybe feel their exhalation on your cheek, and look at look down their body to see if there's any visible chest rise. This evaluation, again, needs to be very quick, 3 to 5 seconds tops. And you then need to go right into chest compressions. Okay, you're not going to do rescue breathing first unless you feel there's a pulse and you're only doing rescue breathing. Hopefully you guys never have to run across this. You're obviously not going to have this happen to you in the hospital, but mouth-to-mouth ventilation gives a lot of people kind of the ick. This is why untrained lay rescuers are encouraged to use hands-only CPR. So for years and years and years, they used to teach mouth-to-mouth with and delivering rescue breaths with mouth-to-mouth with 30 compressions, but they found that almost acted as a deterrent for people to do anything, because people would be like, well, I'm not going to stick my mouth there, so I'm not going to do anything. So, and in order for the American Heart Association to encourage some intervention from, bystanders, they just went, that's okay. You don't have to, you don't have to put your mouth on them. You can just do the compressions. If you are doing mouth to mouth or mouth to like one-way valve or device, you would do, you're gonna be exhaling into a mask or a one-way valve over the patient's mouth. You're gonna do it for over about a second. You're looking again still for that visible chest rise. Know that when you're doing mouth-to-mouth resuscitation, the exhaled air that you're breathing out only has about 16% oxygen in it. So obviously it's not ideal. The tidal volumes that you're going to be able to deliver are going to maximum be about 500 milliliters. If you're doing mouth to mouth on a baby or a child, when you're delivering that breath, you really want to make sure that you're only delivering enough air for the chest. You see the chest move. Because you don't want to cause volume trauma by trying to deliver full full lung full of air into a kid's, a 2-year-old's lungs from your lungs. Um, uh, your book talks a lot about gastric volume, excessive volumes, and how that impacts things like venous return or causes additional problems like gastric inflation. So you really want to make sure that you're not using excessive volumes, that you're not doing too fast of a respiratory rate, because that's going to have negative impacts on your patient. So be careful to not breathe too fast or deliver too much volume to the patients during cardiac arrest. If you cannot do mouth to mouth because of things like trismus, which is when you have your jaws are really tight and you have a hard time getting it open, traumatic jaw injuries or mouth injuries, or the patient you can't form a tight seal around their face with your lips. You could do mouth to nose, where you're going to hold the mouth closed and put your mouth over their nose and try to breathe through their nose. And then if that doesn't gross you out enough, you could do mouth to stoma, where if the patient has a tracheostomy or a laryngectomy, remember, patients with laryngectomies do not have an upper airway that's connected to their lower airway anymore. So anything you try to breathe into their mouth and nose is not going to get down into their lungs. So you have to provide that ventilation over the stoma site for the laryngectomy patients. Tracheostomy patients, honestly, over the stoma site is probably still the easiest and most direct route. And again, you're going to be sealing your lips over the stoma and then using your other hand to obstruct the airflow coming out the nose and the mouth. All right. So one versus 2-person adult CPR. They've simplified this over the years too, that they don't really want you changing your ratios when you're talking about going from 1 to 2-person, because it's just too confusing, and it's just easier to stick with one set of numbers. So if you're performing CPR alone, you're going to give compressions until those AED arrives. Once that true rescuer is present, you're going to somebody's going to take over ventilation. Somebody's going to do compressions. 30-2 is the ratio for adults and children. 3-1 for infants. Okay. When you have more than one person there, which is what your life's going to be like in the hospital, it's really important to remember to switch compressors every 2 minutes. So I mentioned before how chest compressions are very tiring and fatiguing. You are going to feel this in your lower back the next day. You are going to not last that long when you're in the middle of the code doing it. A couple rounds of CPR taps me out. I'm like, oh, yep, I'm not cycling in again. I can't make it the full 2 minutes. It is totally fair to say that and just speak up and do say that, because we don't want to be doing. If you're doing crummy CPR, you might as well not be doing CPR. That high quality CPR is an important piece of these medical responses. So if you physically can't do it effectively or well, there's no shame in that, because we all get to that point, every single one of us. You just need to verbalize that and say, oh, I need a trade out. Nobody's going to look at you and be like, oh God, sissy, get back in there. Your 2 minutes isn't up. This isn't the gym. You're not there for a workout. Just tell somebody that you're not up to going the full 2 minutes with your compressions. And at the 2-minute mark, you should always be rotating those compressors. Because like I said, this first lecture, we're just talking about BLS. You're going to keep doing this until the team that is going to do those ACLS maneuvers come in, and then we're going to talk about drugs and defibrillation and things like that in ACLS, the second lecture. Rarely are you going to note spontaneous or return to spontaneous pulse and breathing until with just CPR. But if that magically happens for you, obviously you're going to stop CPR, put the patient in the recovery position, and, wait for the rest of the team to come and assess the patient and determine what what our next steps are. There are going to be times where the physician might decide that the patient is not, that we're not going to be successful here, and that the physician might call the code before we get too far into it. There's certain situations that happen with patients that you know, additional efforts are going to be futile. So why put the patient through the pain and suffering of going through, the CPR process, which I think you guys have all seen enough of it now to know that it's kind of a violent, extreme situation where you're watching somebody get CPR. It's not easy on the person that's receiving it. So sometimes the physician or the family will decide early on in the code to, stop efforts and let the patient go. Sometimes the physician comes in and decides that, this is, whatever happened with the patient's not going to make it. So people that survive CPR are usually the ones that get help quickly. It's identified quickly or witnessed and get transported to the hospitals fast so that they can have that ACLS started. So, that statement in your book is really related to codes or cardiac arrests that are happening outside the hospital, but that's even true of inside the hospital. The quicker that we identify that the patient went into cardiac arrest, get the code team there, get ACLS started, the better my patient outcome is going to be. Aside from just basic compressions and ventilation, defibrillation has been shown, that early defibrillation has been shown to greatly increase our patient's chances of survival. So, survival rates are going to be highest when defibrillation happens within 5 minutes of that cardiac arrest. Okay. So, that is because the most common rhythm for cardiac arrest is going to be ventricle fibrillation, and that is going to be that's considered a shockable rhythm, which is treated with electrical defibrillation. Okay. The longer your patient stays in VF, the less chance that they're going to be able to be successfully defibrillated, because after you've been in ventricle fibrillation for a while, you're eventually going to move into asystole, which is flatline, where there's no electrical impulses at all anymore, and those patients aren't even candidates for defibrillation. Okay. So as I mentioned, that survival rate is going to be highest when you defibrillate within 5 minutes. Your AED is typically, those basic AEDs that you see in the community are typically only geared to recognize basic rhythms like VFib or pulseless VTAC. So as I said before, kids don't have as many arrhythmias as adults do. So VFib isn't very common in children, but it's common in adults because our old hearts that we've battered and bruised over the years or tend to not function as well. AEDs aren't used in infants, okay? Less than a year old. So we typically only defibrillate patients at over a year old. Okay. So the first thing you do with an AED is you're going to place it on the patient's chest. So you put the pads on the patient's chest. First thing you do is turn it on, because if you're using the ones from communities, they're going to give you verbal instructions. So you turn on the AED, it's going to give you instructions to attach the pads to the patient's chest and then plug the pads into the AED monitor. Once you've done that, it's going to give you a prompt to say analyzing rhythm typically. And when you're analyzing a rhythm, nobody should be touching the patient. So everybody stops CPR, stops ventilating, lets the AED analyze. The AED then will say something like shock advised, meaning that they've identified a shockable rhythm. And it will charge, and you will hit before you hit the shock button, you're going to look at the patient, look at your team members, make sure nobody's touching the patient, say clear before delivering that shock. That is an important step because people team members, caregivers get zapped more frequently than it should happen because somebody's shocked the patient while somebody else was touching the patients. It used to be, if you taken CPR, BLS in the past, you used to be told to check a pulse right after. That is no longer the recommendation, hasn't been for a long time. Now we're told to go immediately back to compressions. So once the shock's delivered, you're going to go right back on the patient's chest and do compressions because you want to make sure it takes a minute, a little bit, or up to 2 minutes for that heart to get reorganized. So you want to keep compressing the heart within that 2-minute time frame. Okay.
This video is intended to help you understand how an AED works. The ECG strip you are going to see is from Steve's actual save, a real person who is alive today because of an AED and some good Samaritans who took action. Once you turn on an AED, the machine will begin to speak to you. Follow the voice prompts. Once the pads have been placed, the AED will instruct you to stand clear and to not touch the patient while it does an ECG of the heart. The AED is designed to determine if the heart is in a normal rhythm or if it needs to be shocked. In this case, the heart is in ventricular fibrillation, the most common rhythm when someone goes into sudden cardiac arrest. Notice how the heart is not beating effectively. It has electrical activity, but it is uncoordinated. The heart looks like it is shaking like a bowl of jelly. When in this rhythm, you can see the heart is not effectively pumping any blood out. This rhythm is deadly and has to be stopped. When the AED reads a shockable rhythm, the AED will either instruct you to press the shock button, or some AEDs are automatic and will automatically shock the person. At this point, no one should be touching the patient. The AED will send an electrical current through the heart and back again. The purpose of this shock is to stop the heart completely for a very short period of time from this uncoordinated rhythm and give it time to reset. Notice how the shock stopped all the electrical activity in Steve's heart for a brief period. Seconds after this shock, our own SA node, the pacemaker of our heart, will try to regain control of the heart and tell the rest of the heart when to squeeze. It can take up to 2 minutes for the heart to reorganize itself electrically after a shock, before it will function again and effectively pump blood to the brain. This is why you will be instructed to begin CPR immediately after the shock. Your job is to push hard and fast in the center of the chest in order to manually pump blood to the brain to keep the brain alive. Your compressions will not interfere with the heart trying to reorganize itself electrically, so do not worry about that. After 2 minutes, the AED will instruct you to stop CPR. It will reanalyze the heart and advise whether another shock is needed. Always listen to the machine and follow the voice prompts. In Steve's case, the ECG picked up a healthy rhythm and therefore a second shock was not advised. In Steve's case, only 1 shock was required to bring him back to life. Steve's heart continues to beat and he is alive and with us today.
All right. Okay, so when you're evaluating how effective your CPR is going to be, again, you want to make sure compressions are adequate, 100 to 120 compressions per minute, that you're compressing deep enough, and both of those things are going to, ensure that there's good blood flow back to the heart and then out to the rest of the body. Okay, ventilation is evaluated through that observation that the chest wall is going to rise and fall. So you as the RT should be focusing mostly on making sure that your ventilation is actually creating good chest wall rise. As I mentioned before, you want to make sure that that chest wall is allowed to recoil after each compression so that the heart can refill. Avoid those excessive rates in ventilation. If I breathe too fast for my patient, again, I'm using positive pressure to breathe for my patient. That is going to increase those interthoracic pressures, and then that is going to decrease the amount of blood that can return to the thorax. And avoid any interruptions, any unnecessary interruptions to chest compressions. Some hazard and complications to be aware of. Don't do a lot of inappropriate head movement. If you suspect a head and neck injury, you would not want to be moving their head around. But even in blunt force trauma patients, only 2 to 5% of those victims end up with a spinal cord injury. But you do want to be concerned about it in patients, especially trauma patients, especially ones with craniofacial injuries. So if they have injuries to their face or their head, you can assume that they took a hit to the head, which could affect their neck or their upper spine. If they have a Glasgow Coma Scale score of less than 8, that also indicates a head injury. So in these cases, you would want to recommend that jaw thrust maneuver and then avoid moving the head side to side at all. If you're having to do repositioning of the patient's whole body, you want to be making sure that you're doing inline body movements. Especially until the C-spine and their spine is cleared. What that means is that you're rolling the whole body as a unit. You're not rolling their torso side to side by keeping their head in and then keeping their head in line. When you roll the patient to check their back or put the hard board behind their CPR board behind their back, you are rolling the patient so that they're rolling like a board. Like that their head and neck cannot move separate from their shoulders and their heads. That just keeps their spine in line so that it reduces any chance of further injury. Gastric inflation is another big complication. I've already shared how much I hate vomit. I do not want my patients vomiting on me, especially when I'm trapped at the head of the bed with no route of escape during codes. So I want to do everything in my power to minimize the amount of air that's going to go into that esophagus and stomach. Okay. Not just because I'm scared of vomit, but also because if my stomach, which sits right below my diaphragm, gets inflated like a balloon, it is going to put pressure on that diaphragm and make it so that that diaphragm is not going to be able to contract properly. And then my lungs will not be able to expand like they're supposed to. Okay. So how do I avoid this? I'm going to make sure that I'm delivering my breath slowly, no fast squeezes of the bag. So think about a nice slow squeeze so that that squeeze is being delivered over a full second. You don't overdo it the volume. So you're only doing enough volume to see the chest rise, and that you're doing those ventilations in between compressions. Okay. If somebody's pushing on the chest as you're trying to squeeze that bag, that air is not going to go into the lungs. So you need to wait until they pause those compressions after 30 compressions, do your 2 breaths, and then resume. They can resume compressions, and you're going to do your 2 breaths after another 30 compressions. That is until that ET tube is placed. Internal trauma. We already talked about how most of these complications are going to be due to poor hand placement. Don't not do CPR just because you're worried about breaking a few ribs on the 100-year-old lady that's coming in. You still want to be doing the CPR, but you do want to be conscientious of where your hands are. So you need to make sure your hands stay over the sternum, and on the lower half of the thoracic cavity, so that I'm less likely to, break a rib that's going to end up perforating the stomach or lacerating the liver or puncturing a lung and causing a pneumothorax or hemothorax. If I puncture the area around the heart, I can end up with a cardiac tamponade. I can also end up with soft tissue emphysema or a sub-Q emphysema. If I have a pneumothorax, usually a lot of times we'll end up with sub-Q emphysema where that air is leaking out of the chest cavity underneath that dermal layer. And when you kind of push on that, you almost feel like the air bubbles popping underneath it. It's kind of a weird, gross feeling. Which they usually the term they usually use to refer to that is crepitus. And so if you feel crepitus underneath the skin when you're palpating, that's usually a sign of subcutaneous emphysema. If your patient had a foreign body obstruction to their airway that cause like the respiratory arrest and subsequent cardiac arrest, you do have a risk of pushing those foreign objects further down into the airway. So that is a complication. We do not do blind figure sweeps to go fishing to retrieve the hot dogs and grapes that are stuck in your airway. Okay. If you see it, you may attempt to remove the object if it's visible to you. And you would do that with a McGill's forceps. Or the doctor might do that if it's not something visible in the upper airway. They would use a rigid bronchoscopy, a procedure called rigid bronchoscopy, where they insert a bronchoscope into the main airway and fish out whatever objects in there. Rigid bronchoscopes only can retrieve objects from the main bronchus. So if it's been pushed further into the airway and it's advanced into either the right or left lung, they won't be able to get it with a rigid bronch either. Some contraindications for CPR are going to include if the patient is biologically dead, meaning that the patient's already cold and has rigor mortis set in, not really an option to start CPR and try to resurrect the dead there. Typically, if a patient has had an unwitnessed cardiac arrest or even a witnessed cardiac arrest, the patient is not going to make it if you don't have an intervention within a couple minutes. So 4 to 6 minutes, you start having tissue brain death occurring if a patient's been apneic for about 4 minutes. And you probably already covered that in CP Phys and just about oxygen transportation and the tissues consuming that oxygen with the oxygen that they have within 4 minutes. So after 4 minutes, the tissues are out of oxygen. If the blood and the lungs aren't going to deliver more oxygen to it, it's going to start going into cellular death. So you're not going to start CPR if you think the patient's biologically dead. Another main reason to not start CPR is if there's like a do not resuscitate order in effect. So if the patient has a DNR in their chart, you're not going to do CPR. I think we talked about this about ethics and legal of respiratory care back in survey, but we also have these things called advanced directives where people can get really creative with how they want their health care. And they might decide that I've had patients have advanced directives saying, I want medications only resuscitation, meaning that they'll take as much epinephrine as we want to pour down their veins, but they don't want compressions, or they don't want, they'll take compressions and medications, but they don't want to be intubated, which is weird for me. But this is patient autonomy at its best. People need to be able to make the decisions that they want to make with their body. So you might run across patients that do have those types of advanced directives to say they want this, but not that. Other types of, we talk about rigor mortis, but there are other situations where you can classify the patient biologically dead and that you're not going to do CPR on them. Like if a patient comes in and they've been in a horrific accident and they've been, decapitated or something like that, you're not doing CPR and trying to reattach their missing body parts. If a patient has severe burns, so if not more than 90% of their body is burned, you're not going to bother doing CPR with them because the chance of survival is very minimal at that point. Or it's actually non-existent at that point. The other one is, when we talk about neonatal patients, is if a baby is born too early, before the date of viability. So babies are considered viable at 23 weeks. There's a little bit of wiggle room where, they might try to save a baby that's, 22 weeks in a couple days, but typically before 22 weeks, it's going to be a hard no. Like, I don't care if the baby comes out and they're crying or they're moving their arms and their legs, we're not going to do any resuscitation efforts on that child. So those are just some examples. Some health concerns with CPR. Again, like I said, the mouth-to-mouth thing was always giving people the big ugh. So it was really hard to convince the general population to do mouth-to-mouth on an individual, but the risk for disease transmission during mouth-to-mouth is very, very small, actually. But you should be using appropriate barriers when you go into patients' rooms to perform CPR. So if you're going to on the code, if you are responding to a code in the hospital, you want to make sure you put your gloves on. Do not, I've seen too many healthcare workers get all excited about going to the codes and not put gloves on, which is bleh. Put gloves on. You should be wearing goggles, honestly, at a code, some sort of eye protection, especially because you're going to be helping with the airway. Bodily fluids go everywhere during codes. You want to protect yourself. I don't want to get any of their whatever in my eyes. I don't want vomit in my eyes. I don't want blood in my eyes. I don't want anything in my eyes. I want it on my hands. I don't want it in my eyes. I don't want it in my mouth. So I think it's totally fair to go to a code. Lots of places have it as their policy that they put isolation gowns on to protect their scrubs, that they put gloves on, they put a mask on, and they put goggles on when they go to codes to just protect their healthcare workers. Know your policies at your locations, but also know that you can escalate your PPE to what you're comfortable with. So if you need, usually there's going to be goggles or face masks on, or masks with face shields on the code card, on every code card. So grabbing one to just protect yourself isn't a bad idea. Using filters on your equipment. During lab, I'll show you that I like to put a bacteria filter on my bag valve mask during codes to protect everybody from anything that's coming out of the patient. Sometimes you have patients that have a lot of blood or frothy secretions that are coming out of their lungs during the situation, especially patients that have went into heart failure first. And that is going to be bubbling up the ET tube and can end up getting into your bag and get, you could be spraying it out your exhalation valve if you don't have a filter on. So putting filters on your bags is another good way of protecting yourself and protecting the other people in the room. One-way valves on the bags is also helpful. And then finally, just making sure that you're throwing away contaminated equipment or cleaning it thoroughly. So a lot of things are single patient use nowadays. We used to have to clean laryngoscope blades and handles. Now most everybody uses single patient use ones, so those go in the garbage. But if you look at your bag and your mask and those types of things, after the code is done, if your bag and mask, which most likely it is, going to be covered in bodily fluids, throw it out and get a new one and get a clean one. Because if you put that at the bedside and it's covered with bodily fluids, or bodily fluids are all up inside of it now, that's gross. That's a breeding ground for bacteria. Throw it out and get a new one. Treating foreign body airway obstructions. So if you have a patient that you suspect has a foreign body in their airway, this is going to be critical that you identify this early on. Patients typically that are having airway obstruction are going to be clutching out their throats, making signs that they can't breathe. This can be very silent though. If you have a complete obstruction to your upper airway, you're not moving any air, you're not going to be making any noises. They just might be clutching out their throat as their only indication. If it's an adult or a child, you're going to try to clear that airway obstruction by doing abdominal thrusts. So that's your Heimlich maneuver. If it is an infant, you're going to first attempt to clear it by doing back blows on the infant to clear the obstruction. If that is unsuccessful, then you're going to do 5 back blows. If you can't get it out, then you're going to flip the baby over and do 5 chest thrusts to try to clear the obstruction. One special consideration with foreign body airway obstructions is with pregnant ladies. You're not going to really be able to do Heimlich necessarily. You can get your hands around the lady's pregnant belly. You're going to adjust by doing the same kind of maneuver, but doing those abdominal thrusts on the chest, so the lower part of the sternum, to help with extraction of the object. So how do you do Heimlich maneuver? You're going to stand behind the patient, wrap your arms around the patient's waist, make a fist, place the thumb midline on the abdomen, slightly above the belly button, but below the xiphoid process, which is the bottom of your sternum. Grasp the fist with the other hand and deliver a quick upward and inward thrust. So you're going in and up. So up and in at the same time. You're going to repeat that movement until the object comes out, or if the object doesn't come out, the patient's eventually going to lose consciousness. And then you're going to start CPR if the patient loses consciousness. For back blows and chest thrusts, that back blows are going to be typically, how I do this is I'm going to hold the baby's head, stabilize the baby's head and neck in my hand. I'm going to lay them across my forearm, so their stomach is going to be on my forearm. Their head is going to be resting in my hand. Their jaw is going to be resting in between my thumb and my index finger. And I am going to be delivering back blows using the heel of my other hand to gently but quickly do 5 back blows between those shoulder blades. If those don't clear the object, I'm going to quickly flip the baby over to my other arm so that their spine is resting on my other forearm. And I'm going to stabilize their head and neck with my hand and deliver 5 chest thrusts. So I'm going to use 2 fingers of my opposite hand, find the middle of the sternum, and do 5 chest thrusts just like you would do like compressions. Okay. If you know, and you're going to keep doing that until the object is cleared. If you see it visibly see it in the oral cavity, you can try to remove it, but do not stick your fingers in anybody's mouth to try to remove anything that you're not seeing. No blind finger sweeps. So you know you're successful at removing the foreign body by usually seeing it be expelled. The patient's going to be able to breathe and speak again. And then they're going to, if they were unconscious or, lethargic, they're going to return to consciousness and they're going to be pink again to show you that their breathing is effective and they've got an effective airway again. If you aren't successful, there are more aggressive techniques that can be used. So that one of those is that you use a laryngoscope blade to open up the patient's airways and a McGill's forceps to try to dig the foreign body out if it's in the lower part of the or in the pharynx area. They can do a transtracheal catheterization to try to remove things from the trachea surgically. If we cannot remove it, they can do an emergency airway like a cricothyroidectomy or a tracheostomy. Okay. As I mentioned before, rigid bronchoscopy and flexible bronchoscopy are options to try to get foreign bodies out of the lungs, but that is not usually readily available, and you need to deal with the code first before you can kind of employ those procedures. All right, so that is the end of your BLS lecture, and I will see you in lab to practice some of these skills. Sorry about the barking dog and yelling at the dog.